Thank you so much for joining the Kentucky REC, Kentucky Regional Extension Center's 2024 CMS Quality Payment Program Notice for Proposed Rulemaking webinar. The information contained in this presentation is for general information purposes only and does not attempt to provide medical, mental health, or any other type of health care service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. Again, thank you so much for joining us for today's webinar. My name is Jessica Elliott. I'm a Quality Improvement and Practice Transformation Advisor here at the REC, and I'm joined by my fellow colleagues, Vance Drakeford, and our Value-Based Programs Manager, Katie Sabitis, for today's presentation. A couple housekeeping items, but just before we get started, wanted to let everyone know that a recording of the slides will be made available and will be sent out to the email in which you registered for this webinar here in the next week or two. And then also, if you happen to have any questions about the content of this particular presentation, we're going to have some contact information at the end of this slide, or excuse me, at the end of these slides, in order for you to reach out to us and make sure that we can help answer your questions to the best of our abilities. I'm sure most of you are pretty familiar with the services that we offer here at the Regional Extension Center. We serve both ambulatory outpatient arenas as well as hospitals and healthcare systems across the state. We're here to help support any type of quality improvement initiative that you would like to undertake and to help support any of those fee-for-service and payor programs to help you succeed as well. A little bit about some of the specific work that we do with our clients related to the quality payment program and quality improvement support. We are here to help you provide at-the-elbow support all the way through the life of the program, from determining your initial and final eligibility, requirements related to participating in the QPP, all the way through attestation, and ultimately in the event of any type of audit support. We're here to meet with you to help identify ways for you to improve, what you need to do to help close gaps, to help maximize your score and your performance in these value-based programs. Now, for today's webinar, we're going to talk a little bit about some of the changes that have been proposed by CMS to the traditional MIPS pathway as well as to MIPS value pathways. We're also going to take a look at some of those proposed changes to go into effect in 2024 for the APM track, which impacts those advanced alternative payment models as well as Medicare shared savings APMs. And then we're going to take a few minutes to talk with you about some of the impacts that we have identified that sit outside of the QPP portion of the PFS rule. We think that some of these areas, while we are focusing this webinar and the content of this webinar on the QPP itself, there are some things that we definitely want to highlight and call out and bring to your attention because we do think that they could be particularly impactful to you and to your organization. So this webinar is based on proposed changes to go into effect for performance year 2024 of the Quality Payment Program. This CMS regulation is actually found in the 2024 payment policies under the physician fee schedule and other changes to Part B payment and coverage policies, including Medicare shared savings program requirements, Medicare Advantage, Medicare and Medicaid provider and supplier enrollment policies, and the basic health program. If you would like to dig into this this proposed rule, I should say, you can reach this rule through the Federal Register. We've included a link to this document if you would like to dig through it. I will say it's about 2,300 pages of regulation. We have also, CMS has also kindly provided a fact sheet highlighting some of the primary changes to the PFS as well as to the QPP and Medicare shared savings fact sheet. CMS does highly encourage, and we also highly encourage you to submit comments to CMS regarding these proposed changes to this potential rule. CMS's last date to be able to submit those comments is going to be on September 11th, 2023 by 5 p.m. If you're interested in submitting a comment, again, as an individual clinician, as a healthcare system or an organization, or perhaps you might want to reach out to one of your professional organizations that you're affiliated with to see if they would be submitting a comment on this rule, because these rules do impact many different levels, many different systems and processes. And this is the only outlet and venue that CMS has to really know what their consumers are experiencing and what our eligible clinicians, the challenges with what they propose. And even if you agree with some of their proposals, CMS wants both your constructive feedback around whether you're in support of it or whether you have alternative suggestions for their proposals. And again, we've listed out some different ways in which you can submit those comments, should you be inclined to do so. Now, for a quick overview of the quality payment program for anybody out there who might just be dipping their toes in the water around what this means. So the quality payment program was actually founded, founded out of Congress. The legislation passed in 2015 from MACRA legislation. So Congress put forth this particular piece of legislation to help carve out and to help create a more comprehensive incentive program for providers billing Part B Medicare billing. And so the QPP, or the Quality Payment Program, has two primary participation tracks. Within this track is the MIPS track, or the Merit-Based Incentive Payment System track. This is what by far the majority of clinicians have participated in so far. We're currently in year 7, and the 2024 PFS is looking at year 8 of this particular program. The QPP was actually created from the sunsetting of several other historical programs, the PQRS, the Value-Based Modifier Program, and then Medicare Promoting Interoperability. Now, MIPS ECs, whenever you are a part of this MIPS track, it is a budget neutral program where you're scored across 4 different categories, and based on your performance in those categories, you can receive a payment adjustment. This payment adjustment can be a negative %, or it could be a positive % based on future payouts, future claims. Now, the advanced APM track, this is for those clinicians who are eligible clinicians participating in an advanced alternative payment model. These payment models are deemed as such by CMS. And if you meet certain thresholds around patient volume or payment volume, you could be eligible to receive an additional incentive above and beyond any type of shared savings that you would enter into. Now, to dig just a little bit deeper into the 2 different tracks of the quality payment program. So going back over to MIPS, we have the traditional MIPS that we have been very familiar with and we've participated in for several years now. This is all measures, all cost measures, as well as promoting interoperability. They're all open on the table. Whatever you would like to report on that is a part of CMS's approved measure list, you're able to do so within traditional MIPS. Recently, CMS has carved out MIPS value pathways. MIPS value pathways are designed to be able to create more specific and specialty-focused reporting for clinicians. CMS received feedback from clinicians that perhaps MIPS and traditional MIPS was not very inclusive of specialty providers, and so CMS has provided and carved out this pathway. It's subsets of measures that align with a particular condition, a particular scope of care, or specialty practice. And so it's, again, this very similar setup to the traditional PIPS program. There's just a very channeled subset of requirements that are required for this program. To 2023 is actually the first year that clinicians can opt in to report MVPs. CMS, again, with this proposed rule, has also set forth some. I won't say that they've not finalized and they've definitely not proposed a sunset date for traditional MIPS, but they've given every indication that they are continuing to look in that direction, that traditional MIPS will go away, and that if you are an eligible clinician, your reporting option in the future will be through MIPS value pathways. If you are, you can continue to report both right now for 2023, but into the future, again, we don't have a proposed date yet, but CMS is still, the language that they're saying in this rule is continuing to move in that path. Advanced APMs, this track, again, it's made up of two different options. So first we have that advanced alternative payment model. That's that subset of ACOs that have a special, they meet certain criteria and requirements under CMS to be labeled as such. And they have both high downside risk as well as higher returns for shared savings. And it's truly about balancing those outcomes with the cost related to care and providing that total care for that beneficiary. If you do meet certain thresholds, again, you can have an additional incentive as a part of this, being a QP or a qualifying participant. Now, the other track is our MIPS APM track, or the APP pathway. This is for those clinicians who are a part of an ACO entity that's been deemed a MIPS APM. So that could be something that's a type of a bundled payment. It could be CPC plus. It could be around Medicare shared savings. Medicare shared savings is probably one of the more common. But it still has to be, a MIPS APM still has to be deemed a CMS approved entity, and beyond that, the MIPS APM list. Again, it's going to be very similar. You're going to be focusing on a condition, a subset of patients to provide care for. There might be some downside risk, but it's not going to be as full capitation as it would be for advanced APMs. And then with that, I will hand the presentation over to Vance, who will talk us through some of the proposed changes to traditional MIPS and MVPs for 2024.
Thanks, Jessica. Hello, everybody. Glad to be with you today. There's several different proposed changes for 2024 that CMS has released. And so let's talk about those for traditional MIPS and the MVPs, like Jessica said. I think one of the most anticipated questions that we get is, what are we going to have to do to avoid penalty for the next year? So for 2024, CMS is proposing to increase that threshold to avoid penalty from 75 points for this year to 82 points for next year. So they're proposing that you would need to at least score 82 out of those 100 points available for your traditional MIPS score in order to avoid penalty and receive that neutral payment adjustment. And if you fall below that, you can see if you're scoring in the range anywhere from 0 to 20.5 points, you would receive a 9% negative payment adjustment. If you're above that 20.5 points up to 81.99 points, you're looking at scoring somewhere between 0 and a negative 9% negative payment adjustment. Now, if you're over the 82 points, that's where you're looking at that positive MIPS payment adjustment all the way up to a 9% positive adjustment. As we think about category weights for 2024, nothing has changed. CMS is proposing to keep that the same for traditional MIPS and MVPs. So cost and quality would remain at 30% of the category weight. Improvement activities is at 15% still, and then the promoting interoperability category would remain at 25%. We talked about that 82 points for the neutral payment adjustment. That performance threshold, really what they're basing that on is an average of the mean of all the final scores between performance years 2017 through 2019. So CMS has done that average of the mean score from everybody to get that 82 points adjustment. So that's where that's coming from. When we talk about complex patient bonus, they are still going to use what they established previously to calculate that complex patient bonus as they did for the calendar year 2022 final rule. Now, the different 4 categories for the traditional MIPS, some different scoring proposal changes for cost. They're going to update some of their policies that they're proposing for improvement scoring to include measuring improvement at a category level instead of at the measure level like it has been for this year. The improvement scoring will be available for cost categories starting in this year, 2023, instead of performance year 2022. And the max score that would be available is 1 percentage point out of those 100 percentage points. Moving to quality, they are going to propose to increase data completeness. We're at 75% now. They're looking at increasing that to threshold to 80% starting in performance year 2027. In calendar year 2022 and the payment year 2024, MIPS eligible clinicians won't receive any bonus points for high priority measures. So that started last year really, and that still is in effect that you won't get any bonus points, unfortunately, for submitting high priority measures. Promoting interoperability. This is really big. They are moving from a 90-day reporting period that you must submit data for to 180 continuous days reporting period. So really it's moving from a quarter time frame to really 6 months. So half of the year's worth of data for PI will need to be submitted that they're proposing for next year. And then improvement activities. There is no scoring changes that they're proposing for that category. So that's some good news, nothing to worry about in that realm. Now, if you are reweighting 3 of your 4 performance categories because of a hardship, you would receive a neutral payment adjustment, even if there's data incidentally submitted for other performance categories. So if by chance you do 3 out of 4 hardships and you're approved for that, you would receive a neutral payment adjustment, even if you have some data submitted through like claims for your quality category. That is not going to mess that up, that neutral payment adjustment for you. As far as eligibility for next year, that low volume threshold is going to remain the same, no changes. In order to be eligible, you'll still have to meet all 3 of those components. So $90,000 or more in Part B Medicare charges, 200 in Medicare beneficiaries, and 200 covered professional services. You'd have to meet at least those minimums in order to be eligible for the program. Small practice reweights, that's still in effect. That's going to remain. And they're going to continue that automatic reweighting for clinical social workers. So that's going to remain the same. What they're proposing to differ is that PTs, OTs, speech and language pathologists, dietitians, and nutrition professionals will not receive that automatic reweighting for 2024. Also, ambulatory surgery centers, hospital-based and non-patient-facing clinicians, groups, and clinicians in small practices will continue to receive that automatic reweighting. So targeted reviews. So if you're looking, we just received final feedback from CMS for the 2023 performance year. So if you've not looked at that, make sure you go into your QPP portal and review that to make sure that looks accurate. And so if it's not, that's when you should submit a targeted review. For 2023, that's October 9th is your deadline for that, just as a reminder. But as we think about next year for 2024, they're proposing to keep that submission period upon release of the MIPS final scores to be open for 30 days after the MIPS payments are released. The They'll have a 60-day period for requesting a targeted review that they're proposing. That's remaining the same. So you'd have 30 days before the adjustments are released, and then 30 days after they're released in order to submit that targeted review. They're also proposing to include those virtual groups and subgroups to be eligible next year for targeted reviews. And just take note of this: if you are submitting, or if you do submit a targeted review and they respond to that and request additional information, you only have 15 days to respond to that to get that back to them. So make sure that you're on the lookout for that if you submit a targeted review. You don't want to miss that deadline. Okay. So we went over some of the generalities of the traditional MIPS and the changes. Let's talk about some specific category changes. As far as the category weighting, I've mentioned that it's remaining 30% for quality for traditional MIPS and MVPs. However, if you're in that APP track or MIPS, APMs, ACOs, quality is proposed to be at 50%. And if you're in actual APM, then that is proposing to be at 55% of the total weight. So it's very depending upon how you submit. Data completeness is going to be 75% through 26. But again, they're proposing to increase that to 80% by performance year 2027. They're also proposing to have a new collection type. So this for next year, they're looking to add what they're going to call Medicare CQMs. And this is only going to be available for the Medicare Shared Savings Plan, ACOs. And it's really just what they call a transition collection type for the advanced performance pathway. Data completeness will still apply to that type of collection type. And then for the CAPS for MIPS survey, if that is a measure that you choose to do, they are proposing to make some amendments to this submission criteria that identifies that survey, a CAPS for MIPS survey as a measure. And it's also going to allow virtual groups, subgroups, APM entities to administer that CAPS for MIPS survey measure. And they're also going to now propose to require that measure be translated to Spanish, and that and then they recommend also translation to other available languages based upon your patient population. For submission for quality for 2024, they're not proposing any updates. You can submit data still through Part B claims for small practices. You can directly and log in and do that and upload. And CMS is going to take the highest score based upon the measures that you submit. And that they've clarified that ECQMs has to be submitted using that CERT technology. So those are the proposed changes for quality. Here are some of the measures that are proposing to be completely removed from all the reporting options. Now, as you can see, many of these probably that's sticking out to me is the influenza immunization and the pneumonia vaccination status for older adults. That is something that they've started doing last year, but they are completely removing it, proposing for 2024. And then, of course, those other measures too in the teal blue. Now, in the yellow, you're going to see they're proposing to remove some from traditional MIPS submission method, but they're going to keep these two, breast cancer and colorectal, for MVP, and then the Medicare Shared Savings Plan for ACO and web interface. So if you're submitting in an MVP and it has those two quality measures, that can be an option. Or if you're in the MSSP ACO or web interface, you would have those two quality measures as options. But traditional MIPS, they're proposing to remove breast cancer and colorectal cancer screening. And then lastly, they're in green. They are proposing to remove from traditional MIPS completely, but keep only an MVP. And that would be your BMI screening. So some of those measures are, a lot of people use. So take kind of take pay some attention to that in case that does come through. Now, the new quality measures that they're proposing, I'm not going to read through these. There's 14 new ones that they're proposing. They have a composite measure, which is called preventive care and wellness, and then some 7 high priority measures with 4 patient reported outcome measures. But you can see those that they're proposing to add to that list. So moving from quality to PI category, the category weight is 25% for traditional MIPS and MVPs, but for APMs and APP track, it is going to be worth 30% of your weight. They're proposing. The most important thing I've mentioned is they're moving from the 90-day reporting window to 180 days. So a full 6 months worth of data that you will need to submit for PI if this does goes through. The prescription drug monitoring program exclusion, they've updated that. So any clinician who does not electronically prescribe a Schedule 2 or Schedule 3 or 4 drugs during the performance period, that can be an exclusion potential. They've revising or proposing to revise that e-prescribing description where at least one permissible prescription, it's written by the MIPS-CC, is transmitted electronically using CERT, and then your numerator statement is going to read number of prescriptions and then denominator generated and transmitted electronically using CERT. Another big change that they're proposing is regarding the high priority SAFER guide. That is going to be required for 2024. They're proposing you would have to attest, yes, that you completed that high priority practices SAFER guide section and complete that in order to receive credit. If you do attest and no and do not complete that, you would receive a PI score of 0, not just for that measure, but for the entire category. So 25%, if you're in traditional MIPS, of your entire score would be 0. So that is very important that you would get that completed and have that on file if that does go through. And then they're removing all the eligible clinician types from the automatic reweighting, except for those clinical social workers that I mentioned a little bit earlier. So improvement activities category, no big, huge changes here. You can see that they're proposing to add 5 new activities that you would potentially be able to choose from. They're removing 3. I don't see any of those 3 that are a huge, a majority of people use these that we've seen, but they are potentially going to be removed. And then they're modifying one of the improvement activities for that use of decision support and standardized treatment. So they're doing that. And then, of course, the category weight is 15% for both traditional MVPs and APMs. And then if you're in that APP, that MIPS APM track, that would be worth 20% of your weight. And then cost. You're waiting for that 30% for MVPs and traditional MIPS. If you're in an APM or APP track, that cost category is null and void. You don't do that. It's already kind of baked into your contract with your APM ACO entity. That cost, portion is kind of built into your contract already. That's why you don't have to submit in those tracks for this category. They're proposing to add some new measures to the cost category, which would be depression, emergency medicine, heart failure, lower back pain, and psychosis and related conditions. So that could affect many of you out there that could potentially cause you to meet or hit the cost category because of those new measures if they're implemented. The case minimum for these, if they are, is a minimum of having at least 20 cases or more. They're also proposing to remove the simple pneumonia with hospitalization. So that could possibly be removed too for 2024. So for improvement scoring, They are doing a little bit of revision on this. As I said earlier, they're going to determine the cost score not at the measure level anymore, but at the category level if this goes through. They're going to do sufficient data is available for improvement data that started with this performance year in 2023. And then if you do get improvement scoring, you can get up to 1 percentage point for that. Now, moving to public reporting proposed updates. This is, they're looking to add language to identify clinicians if they're using telehealth services. And they're going to eliminate those codes there, POS 210 and those modifier 95 codes. They're going to kind of revamp the provider data catalog and remove some files so that it reflects information for the clinician profile on that public facing compare website. And then they're going to show the claims on 13 different categories for physicians so that patient can understand what kind of procedures that the physician does complete, have experience with. And then they're also looking to include cost data to be on the public facing compare site to be for performance year 24. So that to be published in 2026. So cost data could now be for public facing to be viewed and understand that for your patients can have that information. Now looking at the MVP structure, you can see that our triangle here kind of shows the basis of what an MVP format is for. It includes your cost measures, improvement activities, your quality, population health measure, and your PI objectives. So all of those components are built into an MVP. And depending on what MVP that you would choose, those measures are already selected for you to choose from. So you don't have to think about what you want to do, but whatever that MVP is that you're looking at will already have those specific components for that specific MVP for you to choose from. They try to align all those quality and cost measures and all of those measures that it goes with that specialty or specific patient population built around that MVP structure. All the MVPs are going to have the PI and population health measures in that, and then traditional MIPS scoring, program flexibilities and special statuses convey to and relate to that MVP as well. Some proposed updates for the subgroups for MVPs. It would be still voluntary for this year, next, and 2025. And then they're looking to mandatory be required in performance year 2026 and after. As far as eligibility, the subgroups must exceed your 10 level low volume threshold to create a subgroup, and then they'll get those special statuses at the 10 level that kind of impact your category weight. As far as reporting your quality data, it has to be aggregated based upon your subgroup, and it can only include data with the clinicians in the subgroup. Very important. Your improvement activities have to be performed if you're in a subgroup by at least 50% of the clinicians in that group. And then your cost, population health measures, those are all based on your administrative claims. So there's nothing that you have to submit additionally. It's just based on those claims. If you don't meet the minimums for that, you would receive the TIN level score. And then the PI category, all of the TIN group level aggregated data would be used for that. So scoring for updates for that, it's going to fall back on 2023. That affiliated group complex patient bonus score is going to be assigned to the subgroup final score. And if you have an extreme and uncontrollable circumstance, subgroups are eligible to file for that if it's applicable. And then you can be excluded if you are a facility-based scoring at the subgroup level. Now, the box in blue here on the left, those are all the previously finalized MVPs that they have. You're going to notice that there's a couple of them have some strike throughs, the optimizing chronic disease and the promoting wellness. Those are proposed to be removed, and they've kind of combined them. That's what they're combining them for the new MVP that they're proposing for value in primary care. So they're combining those two into one of these proposed MVP groups. So it looks like there's 6 that they're proposing for 2024. So third-party intermediaries. So if you use a registry, QCDR, somebody, maybe a EHR vendor submits for you, there has been some changes that they're proposing. They're requiring third parties to get documentation. They have to submit self-nomination forms, even if the QCDRs and registries use a simplified self-nomination process. That QCDRs and registries have to use identifiers for improvement activities and PI measures. One thing that they're proposing. Another is they have to support, QCDRs and registries have to support a transition to an alternate if they discontinue services during a performance period. So a lot of we have had some experiences where the registry or QCDR in the past has been working with a client, and in the middle of the year they can't support them anymore. Well, now if that happens, CMS is proposing that registry QCDR, they must continue to support them until they can transition to an alternate. So I think that's really good for everybody if that goes through for that proposal. The QCDR measure specs have to keep being published through the performance and data submission period. So they cannot remove those specs until after the submission period is over. So everybody still has access to that. And then one of the big ones is we have a lot of clients that use health IT vendors that will submit data for them, and they are proposing to remove health IT vendors from a definition of a third-party intermediary. So they would not be able to submit because of that for you. So keep that in mind. We'll find out more through the final rule if that does transpire. And then also CMS, without notice at any time, can terminate that third party that does not maintain current contact information. So that could be very good if a lot of times if their contact information changes, no one is notified, and so CMS can immediately terminate them if that happens. Okay, I've talked a lot and had a lot of information. So I'm going to stop talking and pass this on back to Jessica to give you some updates on some APM and shared savings.
Thank you so much, Vance. I appreciate it. So yeah, we're going to talk with you a little bit about some of the proposed changes to APMs, particularly the APP pathway and Medicare shared savings. So as I mentioned earlier, the APP or the APM performance pathway, this is the pathway that you participate in if you're in a MIPS APM or if you're part of an advanced APM that you haven't met that QP or qualifying participant threshold. We'll talk about a little bit about that and some changes with that on the next slide. But first, I just wanted to show everyone, make sure everybody is familiar with what that APP core measure set is. CMS has not proposed any changes to this core measure set for 2024. Vance also, I believe, walked through you with some of the different category weightings. Again, cost is always going to be set to 0 if you're a part of an alternative payment model because cost is hardwired, built into those financial arrangements and contracts that you have through CMS. So you can see if you're participating through the APP, you have slightly different weighting than if you are participating as an APM entity through traditional MIPS. So say you are that qualifying participant that you don't meet thresholds in your APM, you have the option. You can submit this core measure set through the APP, or you can do just a traditional MIPS attestation right now. Now, so digging into some of the updates for qualifying participants in an APM. So just to give you a little bit of context, with the 2023 final rule, CMS actually had intended to end the lump sum payment. The macro legislation actually did not extend any type of qualifying participant lump sum bonus after performance year 2022. And so the final rule reflected that. However, in the Consolidated Appropriations Act of 2023, Congress actually set aside 3.5% as a partial lump transition, kind of a transition bridge from 2022 to 2024. Right now, the legislation is currently written that is starting in 2024, any of those participants in an APM would receive a favorable scaling factor. Other ECs get a 0.25 scaling factor, and so in 2024, a 0.75 scaling factor would take effect and would replace any type of lump sum payment based on your QP status. We do not anticipate, and CMS in the legislation, they would depend upon Congress to set aside any other type of payments for a continuation of a lump sum bonus. We don't anticipate, again, unless Congress intervenes with legislation further this year. CMS is moving forward with proposing that scaling factor of 0.75 in 2024. Something else that changed with that Consolidated Appropriations Act was transitioning up to and increasing the thresholds around QP determination. It was finalized to go into effect at these rates that you see on the screen here in 2023. However, that Appropriations Act actually froze everything at the 2022 level. So CMS is moving forward with this proposal to, in 2024, ramp up back to that 75% of your payments are processed through your APM, and you have to have 50% of your attributed beneficiaries tied to that particular APM model to be considered a qualifying participant. You can achieve a partial QP status, meaning that you would be eligible to submit in the APP track if you have 50% of your payments now and that you have 35% of your patients tied to that or attributed to that particular APM model. Now, again, the difference from those is if you're a full QP, you do not have to submit anything through the quality payment program. You do have to submit quality through your advanced APM model, but that's different and outside of the QPP program. A partial QP does have to submit. They could submit through traditional MIPS. They could also submit through that APP track. Something else that CMS is proposing that is impactful to those participants within an ACO is they're changing how they are going to determine the eligibility. So it's no longer going to be determined at that APM entity or the ACO level. It's actually going to be determined at the individual eligible clinician level to see if you actually meet those thresholds, the 75 and the 50, to be a full QP. Some additional proposed updates are around the promoting interoperability category. CMS has clarified some language stating that all eligible clinicians, QPs and partial QPs within an ACO must report promoting interoperability. There are some exclusions to that. If you as an individual clinician or as a group, if you meet any of those special statuses like being an ASC, ambulatory surgical center, or if you are non-patient facing or hospital based, that automatic reweighting will still carry over for you. However, all clinicians that are a part of an ACO otherwise would be expected to report PI. CMS also, in creating more transparency through public reporting, is proposing to move forward that ACOs must report out that information of those eligible clinicians, QPs, and partial QPs that earn a MIPS promoting interoperability score. Additionally, CMS is proposing the removal of wording around CERT thresholds. So previously, the CERT threshold was set at 75%, meaning that 75% of the participants associated with your ACO or APM entity are required to be on CERT, meaning that they're utilizing their EHR that meets the ONC requirements. CMS is changing that language and removing that 75% threshold and requiring that all participants within your advanced APM that they meet that CERT requirement, the ONC Health IT certification. So you can't have any providers that are on white space. They would have to be utilizing an EHR. And additionally, one last thing related to beneficiary attribution. So CMS is actually updating the model for how they assign beneficiaries to qualifying participants. It's moving from a 2-step to a 3-step model. And in particular, this 3rd step that they're adding is expanding to different clinician types. So looking at nurse practitioners, looking at physician's assistants and such, in order to identify those providers who are within an APM entity that are delivering primary care services. What this is ultimately going to do is it's going to help folks, help ACO entities meet that patient count that has been increased from previous performance years. Some additional updates I want to just quickly touch base with you about is the quality performance standard. So not only when you're a part of an APM do you need to meet your cost goals in order to receive a portion of shared savings, you have to also meet that quality performance standard. And this standard has been set to increase to the 40th percentile across all quality performance benchmarks. And so what CMS has proposed some language going forward with this is that they're going to look at historical years. They're going to take the average of the last 3 years, and that's going to determine what that 40th percentile is across everyone's quality performance category score. And as an APM, you have to hit at least the 40th percentile. Your score has to fall into that range in order for you to be eligible to receive your shared savings at that maximum rate. If you recall, last year, CMS did put forward and finalized some regulation related to an alternative quality performance standard, and they've set that at the 10th percentile. So if you hit the 10th percentile average performance score, you can receive a partial shared savings. Again, this was some additional flexibility that CMS built into the regulation in order to further incentivize the adoption of APMs and ACOs. Again, I mentioned no changes to the APP measure set. However, there is a lot of conversation around CMS's Adult Universal Foundational Measure Set. As Vance mentioned, the new value in primary care pathway for MVPs, that pathway aligns directly with this Adult Universal Foundation measure set. And just from the conversation, it looks like that the APP measure set will likely, over the next few years, we may see it transition to this. So very similar measures already, but they might be adding some more in. So something to keep on everybody's radar. Data completeness for the APP is also aligning with MIPS. So 2024 through 26 is proposed to increase to 75%, with 2027 proposed to increase to 80% data completeness across all measures. Additionally, there's that new Medicare CQM. This is a transitory measure. It's to help those ACOs and APMs who've been reporting web interface. Web interface sunsets in 2024. And so this is to help those practices, those APMs, to be able to start that process of all payer, all reporting, rather than the traditional web interface. And so this will only apply to Medicare Part B beneficiaries that are attributed to that ACO and reporting around those particular measures. Finally, within this regulation, CMS has had a lot of conversation around ACOs adopting specialists and bringing them into the fold of their care for that complete and total patient care. There's been some hesitancy for ACOs to adopt specialists simply because they're not bringing in that primary care beneficiary attribution. And so CMS is encouraging this, and they have suggested that specialists could potentially participate in MIPS MVPs if they have a particular measure set that aligns with the scope of their care. A couple other things for us to just quickly go through are MSSP updates. CMS did finalize AIPs last year. One of the things that they have done with this particular program, again, this is for low revenue ACOs who are completely inexperienced with risk. CMS has created some flexibilities with Medicare shared savings, meaning that you can stay in Track A or Track B through your first entire agreement period, which could be 5 years, plus the first 2 years of your second agreement period that you sign. So you can only do shared savings. It's a low-level shared savings, but you can dip your toes for a longer time in shared savings before you transition to a risk-bearing model that starts out at Track C. CMS has cleaned up some language around that so that no one would be penalized if they did escalate to Track C within their agreement period. Those AIPs would be paid back from shared savings out of the ACO and not directly from the ACO itself, unless the ACO terminates their agreement. If an ACO terminates their agreement, then they would be expected to pay back any and all of those advanced investment payments. And with that, I will hand the presentation back over to Katie.
Thank you so much, Jessica. We are going to take our last couple of minutes together to talk about proposed impacts outside of the quality payment program. So the proposed physician fee schedule for calendar year 2024 would see a 1.25% reduction in overall payment amounts when compared to calendar year 2023. While there are proposed payment increases for certain services like primary care, these would be balanced with adjustments to maintain budget neutrality. The proposed conversion factor for calendar year 2024 is $32.75, which reflects a 3.34% decrease from calendar year 2023. There are also several FQHC and RHC updates that are included in this proposed rule. First, telehealth flexibilities are proposed to be extended. The Consolidated Appropriations Act of 2023 has extended payment for Medicare mental health services via telehealth that are provided by FQHCs and RHCs until December 31st of 2024. In-person visits for mental health services are proposed not to be required until January 1st of 2025. And virtual supervision flexibility using two-way real-time audio-visual technology is also extended until December 31st of 2024. CMS also proposes adding marriage and family therapists and mental health counselors as eligible practitioners for mental health services effective January 1st, 2024. And it is also proposed that addiction counselors may enroll as mental health counselors under Medicare through this rule. Starting January 21st, 2024, it is proposed that payment for intensive outpatient therapy, including occupational therapy, family counseling, education, diagnostic services, and therapy, will be reimbursed at hospital rates for RHCs and FQHCs. CMS has also proposed introduction of HCPCS codes for remote patient monitoring, remote therapeutic monitoring, community health integration, and principal illness navigation services. And overall, these changes encourage FQHCs and RHCs to expand services, enabling them to meet patient needs effectively. And additional Part B reimbursement will incentivize these practices while increasing utilization and reimbursement for community health worker services. CMS is also proposing to address social determinants of health in order to enhance patient-centered care, break down barriers, improve access, promote equity, and uplift historically underserved patients. Recognizing social determinants of health's impact, CMS suggests including an optional social determinants of health risk assessment during the annual wellness visit with additional payment that would be covered by Medicare. This assessment, conducted alongside the annual wellness visit, aims to enhance care quality. CMS did not define the screening tool, but does require that the tool is standardized and evidence-based. And CMS is also encouraging fostering collaboration with community organizations in order to best meet patient social needs. Okay, so we would like to take a second to highlight our top 10 NPRM impacts. Number one is that increased threshold to avoid penalty. Like Dan mentioned earlier, that's an increase from 75 to 82 points. Number two, the PI reporting period expansion. This rule proposes to increase the performance period from 90 to 180 continuous days within the calendar year. Number three, high priority practice guide requirement. CMS is proposing that the high priority practice safer guide will be required for 2024. Number four, the limited automatic reweighting by clinician type. The automatic reweighting for clinician types beginning in the 2024 performance period will be limited to only clinical social workers. Number five, additional cost measures. They are proposing the addition of 5 new episode-based cost measures for program year 2024. Number six, mandated PI reporting across all tracks. Again, CMS is proposing to require all eligible clinicians, groups, virtual groups, or APM entities participating in an ACO to report the MIPS promoting interoperability performance category. Number seven, care compare cost public reporting. CMS is requesting public comment on public reporting of cost measure data from the program year 24 performance during calendar year 2026 via care compare. Number eight, commonly reported quality measure removal. Like Vance mentioned earlier, body mass index screening and follow-up plan, breast cancer screening and colorectal cancer screening are being proposed to be removed. Number nine, removal of HIT vendor for direct submission. CMS is proposing the removal of health IT vendors as an approved submitter type for program year 2024. And number 10, a change in data completeness threshold. Again, CMS is proposing to move to 75% data completeness in 2024, 2025, and 2026 program years, with a further increase in program year 2027 to 80%. So you may be asking how our team of experts can help your practice, and that's a fantastic question. Our team of expert advisors are here to help you not only understand the moving targets associated with the quality payment program, but also to help you analyze your systems, the data generated from those systems, and how your practice can move from your baseline toward your goal. We know that participating in the quality payment program is just one small part of your day-to-day lives, which is why we break the program education and action plan down into bite-sized pieces, so that throughout the year, we're slowly working toward meeting and exceeding your goals. Here at the REC, we strive to be your trusted advisor and strategic partner, and we hope that you will partner with us to keep improving healthcare across Kentucky. We do have some upcoming webinars that we wanted to make you all aware of. Coming up in September, we have our client-only webinars that will discuss attestation prep over the last 90 days. In October, we have a webinar coming up, QPP Year 7, Interpreting Your QPP Feedback Reports. Again, that is client-only as well. And then we do have another public webinar coming up in November, Quality Payment Program Year 7, Year-End Review. We would love to see you all there. We would also like to take a moment to invite you to attend our REC annual conference. The conference will be held on October the 26th from 8:30 to 4:45 p.m. in Lexington. As you see at the bottom of your screen, there's a link for registration in more detail. We would love to see you there. And making meaningful improvement in the lives of your patients matters to us. We understand the complexities and struggles of providing healthcare in a state that faces many social and economic challenges. We want to help make it better for all of us. Please let us be that piece in the puzzle to help you move your quality improvement journey forward. No matter your size, capabilities, or goals, we have an advisor that can help. Please contact us today to find the right service for your needs. Thank you so much and have a great day.